And hello, everyone. Welcome to Greater Living. I'm Mary Beth Marsden. Thanks so much for the members of the studio audience who are here and everyone who is joining us live online. Today, we are talking about the very foundation of our torso, right? We're going to the ground floor, to the basement, but it's important because if the foundation isn't right, everything on top of it is not going to work well either, right? So we're talking about the pelvic floor. And I don't think most people really give the pelvic floor much thought, right, throughout your lives until something is not quite working right with it. And it's a big deal for a lot of people and particularly for a lot of women. So joining us now to talk more about many things that can happen and what can be done about them is Dr. Joan Blomquist, the Chief of the Division of Urogynecology at GBMC. And of course, urogynecology is really the set of what you do is you work on the female, pelvic medicine, and reconstructive surgery. The pelvic floor, the issues with the pelvic floor can affect men as well, and we will touch on that too, but right now we're kind of focus on what happens with women and some of the issues that they face because of pelvic floor issues, right?
Correct. Yes.
Thank you for being with us.
Certainly. Thanks for having me.
Okay, we've got some toys here. I made an X-rated comment about them, so I won't repeat it. Can you see them? Okay. I mean, you know, but we will talk about those in a minute. But I just want to kind of start really basic.
Right.
And, you know, we can kind of, in our minds, think about what the pelvic floor is, but what is it exactly? It's muscles, right? Or a muscle.
It's muscles and connective tissue. So if you think about your pelvic bones, the pelvic floor is what supports everything that's within the pelvic bone. So it's a combination of muscles. The primary muscle is called the levator ani muscle, and then there's a connective tissue support that helps to hold all the organs in place. And the primary organs that we're talking about are the bladder, the uterus, and the intestines are the things that sit within the pelvis that the pelvic floor has to support.
You know, when I looked at a picture of how this kind of looks, it runs from the pubic bone on back. It almost looks like a hammock.
Right, exactly,
kind of.
Exactly.
And and then your bladder's on top, and your uterus, if you're a woman, of course, on top. And then what happens when the hammock
sags,
starts to sag? There are some big problems.
Right. So actually, if you can put up image 1, I think that's helpful. So this is just an image of normal anatomy, where you can see where the bladder is, which is to the right of this image, and then the uterus and vagina are right behind that, and then the rectum is behind that. And what you can't see on here is the muscle, unfortunately, is not in this picture, but the muscle kind of supports that whole thing like a bowl. So if you go to the next image, this shows what happens if you lose support of the uterus. So the uterus can drop down into the vagina, and then on the bottom image shows when it's the most severe, where it actually can come outside of the vagina. And that's called uterine prolapse.
Now, wait, did you hear everyone's reaction to that? Just imagining that happening is really frightening.
Yeah. And usually it's kind of a gradual thing that someone notices. They feel a little pressure, they feel a little bulge, and then over time it gets worse. But every once in a while we'll hear a story that someone says, I lifted this jammed window, or I lifted a big something, from the ground, and all of a sudden felt a pop, and then something was hanging. So that's a little unusual. It's a little more gradual, so it's usually not quite that frightening as it seems when you see that
But
picture.
This is organ prolapse.
Right.
And when we say organ prolapse, we could mean any one of these organs, correct?
Correct. So if you go to image 3, that's a cystocele, which is the bladder prolapsing. So it can be the uterus, it can be the bladder, or it can be the rectum. And frequently it's all 3. Because the risk factors that make one happen tend to make the whole pelvic floor weak. So if something's going to drop, frequently all 3 kind of come together.
I was just going to ask you what's the most common type of
organ? The most common is the cystocele, or the bladder coming down.
Okay. So here we are. Is it usually an older woman?
It's more common as we get older, but
over 50.
Yes, but we do see people even shortly after childbirth that have this. But yes, it is more common as you get older.
Okay. So now we know what the organ prolapse is. And you mentioned it, I think, briefly, but when you were talking about it, that usually people have symptoms and they come to you, and that's kind of where you start sort of the diagnosis. But it's possible to have sort of a partial organ prolapse or maybe a dropping of an organ and not know it.
Right, right. And, because it's sort of a gradual process usually. If we were to examine everybody and do measurements, we would certainly find some mild prolapse on most people who've had a child. And for most people, it never gets to the point that it becomes bothersome, but sometimes it does. It can sort of, if it gradually gets worse over time.
Okay, so we talked about having a child, and that can be one of the causes. But let's say other than that, what could some of the other causes be?
Genetics plays a role. So if your mother and your sister had this, we think that there might be something about the genetics of the connective tissue that can make them weaker and more likely to happen. And also sort of similar to that, people who have other hernias, because this really is like a hernia into the vagina. So someone who has an umbilical hernia, I'm going to start to lose my voice too. Other hernias seem to be at slight increased risk for this.
Can you explain what a hernia is?
A hernia is, like in the abdomen, a hernia is a defect in the fascia that allows the intestines to pop out. So this is kind of a defect in the vagina that allows the organs to prolapse through. And then other things that increase pressure onto the pelvic floor. So obesity, smoking can be, especially if it causes a chronic cough, chronic constipation, people who have lifestyles where they're constantly lifting heavy things. So those are the primary risk factors.
Okay, and we already have a question, I believe, right, John?
Yes, you do. Question number 1 is, can caffeine cause an increase in urine output?
Okay, so we've kind of looped. All right, we're looping back to the urinary incontinence, which I know John was just talking about for the last half hour.
Yeah.
And let's take this question, but we're going to touch on that too. Right now, we're going to focus on the prolapse, but talk about the caffeine factor.
Yes, so caffeine is a little bit of a diuretic, so it can actually make your kidneys make more urine. Plus, it's also a little bit of a bladder irritant, so it can make you feel like you need to go to the bathroom even before your bladder is as full as it normally would. So, yes, it can cause some bladder dysfunction because of that.
And for people who are watching and seeing these pictures, which can be kind of disturbing, and when you think about it, right, know that Dr. Bloomquist is seeing a lot of patients, and it's growing. So this is a problem that affects a lot of people. And you mentioned that there could be a family history, and I would imagine, too, that there are probably a lot of older family members or maybe generations past didn't necessarily talk about this a lot. So maybe there's just no way of knowing.
That's very true, yeah.
So you are seeing a lot of people, and it's also a testament to how many people are watching us live. We have a lot of people watching and asking questions. So it is a huge issue and something that a lot of people are dealing with, and probably over the in history have not talked about it a lot, but we're just going to put it all out there. So any questions are good questions, and we definitely want to take them. And we have one that someone wrote in earlier and just really describing her symptoms and wanted to know what you thought. But she says, I have a sharp pain from my lower abdomen through the vagina. Who do you recommend that I see? Are you sort of the first?
Well, probably like their general gynecologist first, because prolapse sometimes can cause pain, but it usually is more of a discomfort or a pressure feeling. So, prolapse generally we don't say if someone comes in complaining of pain, we're looking for other reasons that they might have pain too. So it could be related to pulling of the tissues, but probably to be evaluated by the general gynecologist first for other causes.
I mean, would you normally say to women, you don't have to live with this? I mean, let's find out what's going on.
Yeah, definitely.
Does it feel like, I mean, would the pressure feel like, for anyone who's had a child, like you're ready to have a baby?
People definitely say that, like this baby is crowning, but it's my bladder.
Yeah, okay.
So,
and don't have twins.
Yeah.
Okay, so, and this same person said, if I suspect I have this, who should I see, and is it an emergency, and does it ever become an emergency?
So generally it's not an emergency because it usually is a slow process, and generally we say it's not dangerous to your health, sort of like the urinary incontinence. It's very inconvenient and it's very uncomfortable, and that's why we do what we do. But it's generally not dangerous. There are sort of two things that we think about when we say to someone we really need to do something. And that's when it comes out enough that it's interfering with you emptying your bladder. And if that can be a chronic problem and you don't realize it, then it could reflux up to the kidneys and cause kidney problems or recurrent bladder infections. The other would be that if it's hanging out so much that the tissue is constantly rubbing, occasionally you can get an ulceration on the tissue, which could become infected. So those are kind of the two things when we say we really need to do something about this. But otherwise, as long as you know about it, you know what the treatment options are, it's okay to take your time deciding. It's not like most people need to have surgery tomorrow or, so it's not something generally that you'd have to go to the emergency room for or something.
When you look at the pictures, I mean, there's just a sense that your organs just wouldn't seem to be so happy in a space that they don't have room to breathe.
Right.
You know what I mean?
Yeah. And it can, for bladder function, it can make it difficult sometimes to get the urine started, or your stream is slow, you're not emptying well. Sometimes the same with the bowel, that you just, stool kind of gets trapped in there and can't get out, and that's very uncomfortable.
Is there a way to reverse a partial prolapse? Is there a way to stop it from getting worse? Are there things that we can do? Because we always want to know what to do, right?
Right.
Can we be doing the Kegel exercises? Can we be, are there things that we can do to improve the situation?
So the two kind of non-surgical treatments for this, the first one is the pelvic exercises, which the physical therapist, Claudette's going to talk about in a little bit more in detail. And in general, you can never do harm by doing exercises, right? There's no risk in doing them. If you can make the pelvic floor muscles stronger and if they can hold things in better, that's great. When the prolapse gets completely out, that's much less likely to be effective. But if it's very mild and just at the opening, then it helps people to deal with it better. The other thing that my props are here for, these are called pessaries, which are devices that go and sit inside the vagina. They're a non-latex rubber. This one is the most common one we use, that folds like this, and then it slides inside the vagina and opens up and helps to support things. And this one is also has a little bit of suction to it, so this is for people who have a little bit more severe prolapse. And these can be used to help to hold things in, and there is some evidence that this can help to prevent it from getting worse. Now, you still have to deal with this and have it in, so it still is a form of treatment, but it may, over time, prevent it from, constantly having pressure and becoming worse, too.
Okay, so these are very common to you, to your eye, but to most of the people sitting here, they're trying to imagine this, right? So this says size 2, so obviously this comes in very different sizes, as we are all different. So is this something that the patient does at home, or is this inserted in the doctor's office? And is
So we fit people for them in the office. One of our nurses, Kim, does most of our pessary fittings. And we kind of joke and say it's like trying on shoes, so we have to find one that's comfortable. And
I used to like shoe buying.
Right. And then that kind, most women can learn to take in and out themselves if they want to. So people who are still sexually active obviously would probably want to take it out to have intercourse. And then some people take it out once a week, leave it out overnight. But it doesn't have to be taken out as frequently as that. So we have some people who either don't want to touch it or can't because of arthritis. They come in once every 3 months, and we take it out and clean it, and make sure the tissues look good, and put it back in. And I have people who've been using these for 20 years. So it really can be a long-term
and this
thing.
is a dumb question probably, but the hole is for the blood, for urine?
No, it's for any discharge that might develop, so that we're not holding discharge up in there.
Okay. And so I just think this would be not comfortable.
Well, the ideal fitting is you don't even know it's in there.
Okay.
It should fit so that it's comfortable, you don't feel it's in there, and you just feel better because it's in there.
Okay. All right. And the same with that one?
Same with this one, although this one is much harder to be able to take in and out yourself. So this one generally is for people who aren't sexually active anymore, and then we take it in and out in the office.
Okay.
So,
I don't know if you have numbers or percentages, but we did get a question, and we talked about this initially too, because this is such a popular topic. Someone did write and said they feel like they're the only one who has this, which makes me sad, because it means they haven't talked to anyone about it, and they want to know if it's common.
Yes.
Percentage-wise,
It's there's the most recent statistics are that at least 25% of U.S. women have some pelvic floor disorder, either incontinence or prolapse, and 18% of U.S. women will have surgery at some point during their lifetime for one of these
the 25?
conditions. No, 18% overall.
Okay.
So if 18% are going to have surgery, you know, there's a lot more people out there who have it, who either haven't addressed it or do some other treatment,
Right.
like physical therapy or one of the pessaries. So
And we should be
very
clear, too,
common.
you seem fine with that. If you think you have something, but it's not affecting your life in any way negative, and that you could just
Right.
live
Yeah.
with it.
Yeah.
But isn't there some power and some benefit to having some knowledge about what
Oh,
might be
absolutely.
happening? Okay.
Right. And we don't mind if people come in and say, I don't really want to do anything, but I want to know what's going on. That's perfectly fine. And when we sort of watch people over time who aren't ready to make a decision about what they want to do, some people get worse with time and some people don't. So, we might say, well, let's see you back in 6 months, recheck these numbers, see if it's gotten worse, and that might help you to decide if, what your symptoms are, if it's getting worse, whether you want to do something about it.
And I guess every case is so individualized that it's hard for you to say most of the time it gets worse, most of the
Right.
time it stays.
Right.
It just really depends.
It does depend, although there's some things that we're learning based on some research of different measurements that can help us to know who might be more likely to progress. So, for example, there's the opening of the vagina, a measurement that we do, and if that measurement is above 4, then we know that there's a higher chance that that person will get worse over time. So those things that we're just starting to learn now that there's more and more research being done on this help us to kind of guide people in their decision making.
Are you satisfied with the pace of research?
I think so.
I mean, I think you would want to gobble up any study.
Yes. Yeah, exactly. Actually, there was. I'll take a moment to tell about a research study that we did at GBMC, which I think is kind of a testament a little bit to the role of GBMC in our community. So this is a big study that was done between Hopkins and GBMC, where the principal investigator is Dr. Handa, who's down at Hopkins, and then I've been working with her. And over the last 10 years, we had 1,500 women who had been GBMC patients, so they delivered their first baby at GBMC, and then we recruited them 5 to 10 years after their delivery, and we followed them over this 10-year time period and watched to see what was happening with their various pelvic floor disorders. Some of them never had any, but it's allowed us to kind of look at the incidence of pelvic floor disorders and prevalence and what changes over time, and that kind of stuff is really helpful for people. And and these are all we're patients at GBMC that were willing to come back every year for 10 years for us
Yeah.
to examine them and kind of follow them.
I mean, until you have
So-
data, sometimes you're just, it's all
Right,
anecdotal.
right,
and
exactly.
It's nice to have some numbers.
Right,
And be
right.
able to back that up when you talk with somebody new who's coming
Right,
in.
yes,
I asked you about this before when we were off camera, and I was surprised, actually, because it seems like something quote-unquote dangerous could progress and could happen if this goes untreated. But you left me with the sense that really it can be incredibly life-changing, it can be uncomfortable, but the danger factor really isn't so great. Is that right?
Right. But I think kind of what Dr. Jacobs was saying earlier when someone asked the question about having to get up at night. And, yes, having to get up at night is not dangerous, but how it impacts the rest of your life. So if you're not doing your regular exercise because every time you do it, you are leaking urine or something is bulging out, then that impacts your overall health. So it's part of your overall health, but per se is not dangerous.
Yeah, if you can't get sleep, I mean,
Right,
it's
right,
can affect
exactly.
everything.
Yeah.
Another question, John?
Actually, we have one comment and 3 questions. So,
Okay.
I'll start off with the
In
comment.
rapid fire, please.
You bet. Doctors Blomquist and Jacobs are the best. They truly care for the well-being of their patients. They are excellent providers and educators, and that's a comment from Alita. So here's a question from Jessica. Jessica asks, can you explain stress incontinence?
Okay, so stress incontinence is leakage that occurs when you do something physical, like a cough or laugh or sneeze, and it's related to weakness underneath the urethra. So the urethra is the tube. If my fist is the bladder, then the urethra is the tube that you urinate out of. And when there's something that puts pressure on the bladder, the urethra is supposed to close to prevent you from leaking. And if that closing mechanism isn't working properly, then every time, or just sometimes, when you cough or sneeze, then leakage will happen. So that's what stress incontinence is.
And for anyone who's had a baby, that can often happen right after
Yes,
for a while. But that can
Correct.
strengthen. You can get
Yep,
that back.
Yep, absolutely. And that's Claudette can talk about that with physical therapy, that pelvic floor exercises can definitely help to improve that.
We'll be talking about those Kegels, too.
Right.
Okay, next question.
Sure. This question is from Judy. Judy asks, could you discuss treatment options for, and pardon my pronunciation, pudendal neuralgia?
Ah, all right. So that could be an hour discussion, but just briefly, the pudendal nerve is a nerve that comes through the pelvic floor and then innervates the opening to the vagina and parts of the vagina. And if that nerve is irritated for some reason, it can cause a lot of pain. So sometimes we do nerve injections to that area. Sometimes physical therapy that involves kind of releasing the nerve can be helpful. There are surgical procedures that some specialists do where they actually surgically have to kind of release the nerve if it's entrapped. And then some medications sometimes help also.
And this other question from Allison. Allison wants to know, what kind of foods are considered bad for the bladder?
So things that kind of irritate the bladder make you more likely to feel like you need to go all the time. So the big ones that we always talk about are caffeine and things that are really acidic, so oranges, grapefruits, tomatoes, and alcohol. Those are probably the biggest things. There's some evidence that sugar substitutes also can be very irritating to the bladder for some people.
I definitely want to take some time to talk about this because Dr. Jacobs broached it toward the end of her conversation with John, and it was a kind of one she wanted to make sure that she qualified because it can be controversial. And when we're talking about surgery, so anyone who's watched TV lately or over the past many years has heard the attorneys, whatever company or whatever law firm, talking about vaginal mesh,
Right.
And scares you enough that you're like, I'm never getting that. Something bad must have happened. So let's talk about what that is, what's changed with the surgery, and when it might be necessary.
Right. So, sort of briefly, the primary surgery that has been done for years for pelvic organ prolapse is to go surgery through the vagina, where we use your own tissues to do the repair. So frequently it involves a hysterectomy, not always, but we dissect down to the tissue that's weak and we sort of tighten it up by using a row or two of sutures and resupporting to ligaments, again, using just your own tissues.
Before you continue, I just want to ask, do you remove the uterus because it's just extra, you don't need it, and maybe you don't need it, depending on what age you are,
Right,
and because
yeah.
it's just extra weight on the
Theoretically,
pelvic floor?
and
Okay.
sort of historically, it was always thought that taking the uterus out gave us a better repair, that we could get the support better, and partially because there wasn't weight on it, especially if the uterus is what's prolapsing down. But there's definitely a recent trend towards women wanting to keep their uterus and realizing that maybe we really can get just as good of a repair if we leave it. There's still, controversy about that, but it's very reasonable that we can still, resupport the uterus unless there's something like the uterus is enlarged or someone's had cancer or they're at high risk for cancer or other reasons that we want to take the uterus out of there. But there is a little bit of a trend towards keeping the uterus if women want that.
Okay.
So that's sort of the traditional surgery, is using your own tissues going through the vagina. But then for more advanced surgery, prolapse, we used to do surgery with an incision on the belly where we would use some sort of mesh or graft to re-support things up to the sacral bone. We now can do that laparoscopically, and it's a very effective treatment. So about 10 or 15 years ago, the thought was, well, can't we get the best of both worlds? Can't we put the mesh through the vagina, have a less invasive surgery, and have it work better because we're using mesh instead of your tissues that are already weak? And anatomically, it actually works really well, but about 15 to 20% of women would have complications from putting the mesh in through the vagina. It seemed like it would work its way into the vagina and cause a discharge or bleeding, or for some reason, putting it through the vagina and how we attach it seemed to sometimes make it shrink so that then they would have pain. So because of that, it's really not very commonly done anymore that we put mesh in through the vagina, but putting the mesh in through the belly where we're not making an incision on the vagina and it's attaching to different ligaments seems to work very well and is considered very safe.
So having it done laparoscopically seems to be the game changer.
Correct, yeah, because it's less invasive, but
Why
still...
would you do it any other way then?
Well, because still going through the vagina is the least invasive. because we're using a hole
But
that's already there.
15% of the people who do that could possibly have pain or something, right?
No, that's only if you use mesh. So going
Okay.
through the vagina and using your own tissues
Okay.
is still probably at least the most common surgery
Okay.
that we do. And so we still reserve the mesh even when doing it laparoscopically for people who have more advanced prolapse. You know, using mesh even laparoscopically still has slight risks. The risks are more like 2 to 4% compared to that 15 to 20, so it's a huge difference. But you still have to balance benefit and risk when deciding which surgery is better.
And what is the benefit in the end? Let's say it goes well and you don't have pain.
Right.
Is that
The
it?
benefit is that we think it will last longer, potentially, because it's a permanent thing and your tissues can still age and change over time, and a better success rate.
How long will it last? Do you know?
No, not really.
Okay. Have you ever done have you ever had to redo one?
Yeah. But, you know, generally there are studies that have looked at least 15 years out. And if we think if people are doing well at that point, there's a pretty good chance they're going to continue to do well.
If someone has had the vaginal mesh and they're sadly, unfortunately, one of those 15%, a part of that 15% that's had pain or maybe bleeding, can you remove it? Is there a way to repair it?
You can remove it, but still, unfortunately, about 50% will continue to have pain. So it seems like sometimes we just can't get rid of that pain.
So I'm sure that's a big question for a lot of
Sure,
people.
yeah. Yeah.
And we have another question.
Yes. Sorry. Can you, Dr. Blomquist, can you explain urge incontinence?
So urge incontinence is what Dr. Jacobs was talking about earlier. It's also called overactive bladder, and that's when generally people feel like they need to go to the bathroom frequently and have the urge to go and just can't quite get there in time.
I thought it was interesting. Dr. Jacobs brought this up too, and I didn't realize the connection with bladder infections and sort of the pelvic floor and how that can kind of all go together. Can you talk about? Someone asked a question: if you're frequently getting urinary tract infections, and I know a lot of women will get that more than others, right? But this particular person said every 2 to 3 months. Then they're kind of thinking, is this a cancer sign?
Right. It's
Potentially.
it's unusual that it's a cancer. You know, we're always thinking about the possibility of that, especially if there's blood in the urine. But cancer is less frequent in women than in men, bladder cancer at least. And, you know, just in general, a lot of women have recurrent bladder infections. So if the things that we do to prevent infection aren't working, then we will sometimes do a further evaluation, such as a cystoscopy, to look in the bladder to make sure that there's not a focus for that infection, like a stone or a cancer or something like that.
You know what I'm struck by too is that just in conversation about this topic, it really alleviates a lot of fear.
Right, yes.
And where you're talking about, I
yes.
think there's probably a lot of fear there for people who aren't informed. I think we have another comment or a question.
Actually, this is a comment from a grateful patient, and she says, over 11 years ago, Dr. Blomquist performed her magical surgery on me. Best decision, best doctor, best hospital, best everything ever. Thank you, Dr. Blomquist. You did magic. The testing and the elevated quote-unquote queen chair are a bit humiliating, but that too passes. I still thank you again and again.
And that's why you do what you do, right?
That's right.
What's the
right.
queen chair?
So the queen chair is our queen nurse Kim gets to use the queen chair all the time, which is how we do bladder testing to evaluate for incontinence. So it actually looks very much like an old-fashioned birthing chair. But you know, a lot of this stuff is a little embarrassing, but you know, we try and make it a little fun when you come in, and everybody in our office, you know, our nurse and nurse practitioners are all very nice, and that I think people are, you know, they're kind of relieved after they've had testing and things done, but they're like, you know, it really wasn't so bad because Kim is so nice, or this person was so pleasant that that makes a big difference if the environment is nice.
Yeah, and then
yeah.
Obviously, then if it improves your
Right,
quality of
right,
life,
exactly,
worth it.
exactly.
I don't want to let you go because there's a question here that I know is probably near and dear to your heart, and that's mission work
Oh,
that you're
yes.
involved in, and we want you to
Right,
be able
sure,
to touch on
sure,
that.
Yeah. So for the last 12 years, I've been involved in an organization called the International Organization for Women in Development, which is a nonprofit organization that the primary focus is to help women who have obstetrical fistula. And a fistula is when there's basically a connection between the bladder and the vagina, or between the rectum and the vagina, that happens as a result of childbirth injury. So we don't see that very often in countries like the United States, but in low resource settings, some parts of Africa and Asia, this is not an infrequent occurrence. So our group goes, the group goes 3 times a year. I usually go once a year, and do surgeries to help fix these women. This is an image of the last 7 years we've been going to Rwanda, and this is outside of the hospital where we work in Rwanda, and it's the 2 tents that the hospital puts up for when the women
Wow,
come.
that's a great picture.
So this actually, one of the fellows working with us took this picture on our most recent trip in October. So it's a really good group that we go with, and I think.
And how do you change lives? Like, what's the difference between before and after for a lot of these women?
Generally, if they have a fistula between the bladder and the vagina, then they're just constantly leaking urine. It's not just like stress incontinence where you leak just when you cough, or urge when you have the urge. This is just constant because there's a hole. So we do surgery to fix the hole, and it's about 90% effective. So it can make a big impact. Frequently their husbands have left them. They've kind of been shunned by society. They can't work because they don't.
And those look like young women, too.
Yes, a lot. And one of the times when this most frequently happens is actually when someone is, their pelvis isn't fully developed, and having marriage at a young age is one of the risk factors. So 14, 15-year-old girls who are having babies, and then they get stuck in labor because there's no access to have a C-section. And unfortunately, about 90% of the time the baby dies too. So you don't have a baby, and you then have this leakage. So we're hopefully at least making it so they don't have their leakage anymore.
Great.
Yeah.
Thanks for doing that.
Yeah.
And just back to our conversation, full circle, if you've heard anything that seems like it could be you, or maybe you're thinking, it's about time I figure out what's going on down there, call your office,
Right,
and
yeah.
maybe you'll have to
Absolutely.
sit in the queen chair, but it's not so bad.
We'll have to have a crown.
Dr. Blomquist, thank you so much
Certainly.
for
Yeah.
being with us.
Pleasure.
Really amazingly
Like my
informational.
props.
I mean, I don't know. I've never seen this before, but you say it works, and I believe you.
Yeah.
So thank you so
You're
much.
welcome. Yes.
And our next guest also brought show and tell, but in a physical form. So that'll help us kind of understand what's going on, too. And when I first started thinking about pelvic floor disorders, I thought, gosh, how can we prevent it? What can we do? How can I live my life better? And, sometimes you can't prevent it. Sometimes it's just a matter of your genetics, or maybe, those 3 kids you had is leaving you with this particular scar. And you can't do anything to sort of prevent it. And you do need a doctor's help. But there are ways to also come back from surgery that are probably better and quicker. And there are some exercises that I'm sure you can do that would help your quality of life. And so Claudette Cole is a physical therapist at Rehabilitation Medicine at GBMC. And you see women and men. You were very quick to point out. So we'll talk about both, because I feel like we haven't kind of looped the men in here. And they have a pelvic floor too, right? So
That's right.
and you've brought a nice demonstration of this is the pelvic floor, or what kind of
The
is
whole-
leaning on it?
It's the whole
These are your hips,
pelvis.
right?
Yes.
All right.
Do you want to see the pelvic floor?
Love to see the pelvic floor.
Okay. I'm going to pull the organs out. Those are right in the front. Okay, bladder, uterus, and rectum. But what I wanted to show you is, if you look down through the top, all the red down there, those are your pelvic floor muscles, and they're sitting in there in that kind of hammock or sling configuration. So you can see how they really run down underneath the pelvis. It's the floor of the pelvis.
Oh, wow.
It's amazing.
Yeah, that's a great model. So your weakness, and I'm just going to ask specifically,
Sure.
Does the weakness happen in a certain part of the pelvic floor more than others, or there's just no way to know?
It's hard to really.
It's not like one
tease
weak
it
area that's
out.
like,
An
okay.
area could be a little weaker than the other side.
Okay.
Sure.
So you see people when? after surgery, before surgery, to avoid surgery? Like when people come to you, what are their needs in a range?
So they come at any point. Could be pre-surgery, post-surgery. They come for usually complaints of urinary incontinence.
That's clearly a big one because we keep getting questions about that over and over.
They may have the symptoms from prolapse. So they may have that kind of vaginal pressure, bulging sensation, and that's bothersome. We'll also see women during pregnancy and postpartum because certain issues can arise during those time periods related to maybe pain of the pelvis, pain in the back, urinary incontinence. And then we'll see also folks will come in with constipation or some bowel issues, pelvic
So this
pain.
can affect all kinds of. So it can really affect the bowel as well, just if you've got pressure or organs in sort of the places they're not supposed to be in.
Well, so you can have increased muscle tension that will affect your bowels.
So I would imagine as a patient, I have seen a doctor of some fashion, whether it's my gynecologist or a urogynecologist, and then I am referred to your practice.
Yes.
Okay. So you kind of look and see what the issues are and how you can improve my life.
Right.
Right?
Right. We'll identify any musculoskeletal issues that are potentially contributing to the problem and help kind of normalize that.
So you've got the referral. We come to see you, and how do you evaluate? You take what the doctor has found maybe upon evaluation, and then how do you take that further?
So the first day is the assessment, and we'll have a conversation about what they're here for, what their questions are, and I'll ask questions about how their symptoms are, and really get a feel for what they're struggling with from a functional standpoint. And then I'll assess kind of head to toe. We're going to look at the spine, we're going to look at the trunk and the pelvis, and see if we can identify any issues that are potentially contributing to what you're there for.
Do you ever find the drop off between people who get some sort of diagnosis and coming to you? I'm just wondering, I'm sure you still see people who are still kind of embarrassed to tell you what their symptoms are, right? And it's uncomfortable. But I'm wondering if they get through the doctor portion and they get to you, they've kind of gotten over that and you can get right in there. Or you still have to kind of.
So sometimes
Depending
the
on the
first day
person.
they're nervous. So hopefully I put them at ease.
Right.
The more we chat about it, I usually see the discomfort come down and try to make the environment easy for them to feel
And is there
comfortable.
when I have physical therapy for a broken wrist or what have you, or broke my knee too, and there was a time frame on my recovery, right? I got a certain amount of physical therapy. Is there a time frame for pelvic floor issues, or could this be an ongoing thing for a long time?
Well, typically the course.
And I don't mean that in a bad way. I mean that in a good way.
Sure. The answer really it depends. A typical course would be somewhere between 4 to 6 weeks, seeing someone maybe for once or twice a week, depending on what is needed for that particular issue.
And I know it's going to depend on the individual, but can you give us an idea of what you do in those 4 to 6 weeks? And is there a lot of homework?
There is a lot of
I
homework.
figured.
Always. So again, depending on what they're coming in for, if we've identified that there's dysfunction in the pelvic floor, we want to address that. If they have increased tension, we're going to work on retraining those muscles to not hold so much tension, so that then they're in a better position to get stronger and be able to provide that control if they're having leaking, or better support for the pelvis. Those muscles are really important for our stability and support for the trunk. So we might work on that.
I want to ask you about that.
Sure.
I'm going to get to the question for just a second, but I want to ask you, how can you train your pelvic floor muscles not to hold tension?
Great question. Great question. Well, we talk a lot about how to think about those muscles, how to become aware of them, and then we can utilize things like biofeedback, which picks up muscle tension. So wherever the muscles are that we are working on to bring tension down, we can have sensors that are picking up the tension, and we have a nice readout on our computer, and so you get visual feedback on what's happening, what your efforts are doing, and we talk about how to think about it, bringing down the tension in those muscles.
So So literally, we're trying to do stress reduction all over, and that will affect.
We can, yes.
Yeah.
Yes,
Okay. So
absolutely.
are we going to meditate a little bit too and do some
Could be,
breathing?
that could be, breathing is very important.
Yeah, you mentioned breathing. So people who work out, so people think, I'm in great shape, I work out. But if you're doing that one really bad thing at the gym, what is it?
Holding your breath is really bad. So holding our breath can create a lot of intra-abdominal pressure, and that puts a lot of pressure downwards. So if we have issues of organs maybe dropping down a little bit, we wouldn't want to contribute to that. So in therapy, we would work on kind of managing that, becoming aware of what activities we do during our day that increase that intra-abdominal pressure, and being really aware and figuring out how to manage it.
Yeah, because how many of us will move furniture, let's say, you want to rearrange the living room, and you hold your breath because you think that's giving you more strength as you move the sofa,
Right.
but we need to breathe through that.
Right, and then contract the appropriate muscles to provide better support.
So there is a lot to learn. All right, we have a question?
This question comes from Stephanie regarding pelvic floor therapy. She says that I heard they electronically stimulate the nerves. Does that hurt?
Okay, I'm not sure what that's a
So
reference.
I'm almost envisioning you put like electrodes there,
Yeah.
right? And you give it a little zap.
So we can use electrical stimulation for a variety of things. One is to help recruit muscles that are kind of slow to recruit. That can be done with both external leads or internal sensor. In some cases, it could be uncomfortable, but for the most part, I think it's okay.
But it's proven that it works, and it kind of get things rolling. Your type of physical therapy is not in the traditional rehabilitation kind of group that I've seen.
Okay.
Is that correct?
Correct.
So can you just talk about that a little bit? You're
Sure.
not in the sort of the sports medicine type.
Correct.
That's what when we think of physical therapy, we're thinking of occupational therapy, physical therapy.
Yeah,
but
out
yours
in
is
the
very
gym environment.
Yes, yours is
Okay.
very specialized.
Sure. We would hold all of our physical therapy sessions in a private room, and because often there's one-on-one, there might be a little bit of internal treatment sometimes, but it's always most of the time it's in a private room, closed door.
You kind of do internal type. Okay.
We potentially would use techniques to help reduce tension in the musculature if you have trigger points. So we might do some gentle stretching when it's appropriate.
Stretching. So I'm curious, can you describe like what are these stretches that we could do at home, or you're like physically you're manipulating the muscle? Is that what you're talking about?
So
Okay.
it could be relating to any muscles really that are attaching in the vicinity of the pelvis. So they could even be hip muscles, and we all know how to do stretching of our hamstrings or quads, stretching like that.
Do you use heat or ice for any purpose?
Not typically.
Okay, so that's not
typically
the same kind of thing. I would imagine that people who are finally getting some treatment for whatever their discomfort is, and then realize they come to you, that this is a whole new realm of recovery that they probably didn't even realize that they could utilize.
So we often get that comment. The patients arrive and they
What
say,
is
"Wow,
this?"
I've never heard of seeing a pelvic therapist. This must be new."
Right.
Which is not.
Okay.
But, I think there's not many pelvic therapists around. That's part of it.
So you mentioned to me, and you wanted to make sure that I knew too, that you see men as well.
Yes,
So
we
can
do.
you just talk about sort of the range of issues that you see and how you
Sure.
help both sexes?
Sure. So we'll see, often we'll see men pre and post prostate surgery, because the research shows that if you can work on strengthening pelvic floor prior to surgery, it decreases your risk for incontinence afterwards. So we like to see them before, but it is also helpful afterwards if they don't get to us before. So we'll also see men for urinary incontinence, sometimes constipation, things like that, pelvic pain.
When people, are you, I'm just going to say, does insurance cover what you do most of the time from what you've seen?
Yes.
Okay.
So
I didn't know if you were
Pelvic-
like an extra special add-on that.
So pelvic physical therapy is standard physical therapy care. So most insurances consider that just regular physical therapy care. So it should be.
I'm curious too, like how, just this is a personal question,
Sure.
but you're doing physical therapy. It's amazing how you can improve someone's life if they're willing to also put in the work, right, and the time. What in your mind was like, this is my specialty, this is what I really want to focus on, other than the more traditional physical therapy?
Well, so I did traditional therapy for many years.
Okay.
And as I worked with patients, started to become more aware of these issues of incontinence and how it was really changing people's lives. You know, they were staying home more, afraid to go out, leaking in public places, struggling at work. And so I started to get very interested in terms of learning how to treat this issue, and looked into it. And once I started the training, I realized that
This is
is
it.
so rewarding to be able to help women and men be able to.
Many of whom are suffering in silence.
Yes.
I have to tell you just a quick story. My mother is 81, and she was watching the President Bush funeral, and she kept going back to this one theme. What if they have to get up and go to the bathroom? They've been sitting there for an hour and a half. She was obsessed on it, and she just couldn't imagine it for herself. And I thought,
It's really-
and I kind of sort of blew her off a little bit about it. I was like, "Oh, Mom, they're fine, they're fine." But now, and when I think about it, I'm like, this is a huge issue for her. And so wherever she goes, whether it's our family Thanksgiving, she has to know she can find the bathroom. She has to think in those terms, and that's what she was focusing on when she was watching this.
Oh.
I need to send her to you. So
You
if I
do,
did,
you do.
how could you help her?
So again, I would do a thorough assessment and identify how her muscles are performing, because we can really call on those muscles to help provide that control. So those pelvic floor muscles need really good coordination along with the hip and trunk musculature. So we look at the coordination of all of that to provide that great control, and also look at behaviors. Behaviors can making small, subtle changes in behavior can make a big difference.
And when you say behaviors, when you drink or eat or so forth.
Time of day that we drink, how much we're drinking, what we're drinking, things like that.
Okay, so when we think of pelvic floor, we think of Kegel exercises, or how else do you pronounce it?
Kegel or Kegel?
Kegel.
It's
I
pronounced
think
both
I've always said
both
Kegel,
ways.
but so we want to talk about exactly what those are, because sometimes I think I assume that people know, but I'm not exactly sure they do. And how do we know if we're doing it right? And also what
Okay.
else is available as far as being able to strengthen on our own our
Okay.
pelvic floor?
Okay, well, I'll start with the second part.
Okay.
So we use our pelvic floor muscles without realizing it with every movement. Okay, so even just sitting here and sitting up, my pelvic floor, yours, is already engaging. So we're using those muscles all day long. So basically any movement, any exercise can be performed to keep those pelvic floor
So
muscles
another reason to
fit.
keep moving.
Yes. So we do need those pelvic floor muscles to be well coordinated. In some cases, they do get either underused or weaker, and so we want to make sure again that they're working like they're supposed to. So we want to start with the basic Kegel, and the basic Kegel is a contraction of your pelvic floor, and we want to isolate it so that we have really good awareness that, oh yes, we found those muscles, we are working them, and then we can incorporate them in with other exercises.
All right.
So
So how do we know we're doing a Kegel correctly?
All right, so I'll run you through my
Please.
my spiel. Okay.
And also, because this is always a
Sure.
big bone of contention, how many? How do you do it? Do you hold? Do you just count to 50? You know, how do you? What do you
Sure,
feel is the
sure.
best way?
Okay. So I showed you the model that how those muscles run right down through the bottom of the pelvis. So they run down through your groin. Okay. So for women, I instruct them to think about where the openings are. You're going to think about closing those openings. Okay. So you want to think about rectally. You're going to keep yourself from passing gas. Okay, you're going to keep yourself from leaking. That's the muscles in front around the vaginal urethra area. So you want to feel tension around the openings, and you want to tighten them a little bit more. And now visualize those muscles are shortening, so they're moving inward. So if you're sitting
you're
in a
tightening.
chair, so if you're all trying it out there, those muscles
You don't have
are
to tell us
moving.
if you are, but
Those muscles are
I want
moving.
everyone to try it.
That's right. Here's your homework, right? Those muscles are moving away from the chair. They're moving inward, okay? Remember, because they're sitting in there like this. They're shortening. They're moving inward, okay? So we're drawing those muscles up and in. Think the elevator. We're bringing that elevator up, Now we're holding. That's the endurance. Okay, we need to have good endurance. Then when we relax,
How long do you hold?
So again, it depends. You know, getting assessed by a pelvic therapist, we would determine where they are at the moment. We should be able to do 10-second contractions, but often we need to work up to that.
Okay.
Okay? So you've got that elevator up, and now you're going to hold. That's the endurance part. Then you're going to relax.
So the door's opening on floor 3. Doors
Come
closing.
close. And that elevator is coming back down as you relax. Okay? And you can sometimes feel that really well when you're sitting against a firm chair. And so you could visualize that elevator moving up and coming back down. And so then you would practice those. We might start out with holding for maybe 5 seconds. Again, it depends on.
How many times should the elevator go up and down?
Well, I would start with trying somewhere between 10 and 20 contractions, and I would do that twice a day.
Okay. The car, is that a good place to do it? I feel like the car's a good place.
You could, but the seat's kind of soft.
Okay, so it needs to be a hard seat.
Well, it doesn't need to be, but if you like that awareness from what you're sitting on, a firm seat would be a little better. But certainly a car would be fine.
Are you guys all familiar with all of that?
Yeah.
Okay, see, this is a very worldly crowd that we have here.
But I will say, getting assessed, you know, we can determine where they are that day because body position changes.
So you
how-
might time someone on how long they can hold that elevator up.
Right. And then that would actually help us determine appropriate exercise because body position will change the resistance on the pelvic floor. For someone who doesn't have a lot of strength, if they're, you know, barely able to grab those muscles, we'll start with exercises in the lying down position. Someone who's a little more advanced would be able to do them sitting up because then you're drawing those muscles up against gravity. And then standing would be harder, and then standing and moving would be the hardest.
Is there any proof that doing these, whether you have a problem or not, can prevent a problem down the road? Or is it just anecdotal evidence, or
Well, so the studies have shown
it's not a bad thing, right? It's never a bad thing.
Right, it's never a bad thing. We need those muscles to help with the stability of our trunk. So they're super important. They work with the pelvic trunk musculature to provide that support. So they're really important muscles. So whether they prevent, that's
Right.
really hard to prove.
They don't
but-
look good on the beach, but they're very important muscles.
Right.
We need to
right.
think about them. John, did you have a question? You were holding up a... No? Do you have a question for you? Okay.
Good, thanks, Mary Beth. I'm all right.
So for the men in the audience?
Yes, for the men.
For the
John,
men,
you
I'm
want to come
sorry.
up and...
I left you out.
Yeah.
So for a male doing a pelvic floor contraction, you're going to think of that rectal part, keeping yourself from passing gas.
A tight sphincter.
Yes, and then draw up the same elevator analogy. Men have all these muscles as well. Swing through the pelvis just like they do on a female. There's just a little bit of variation, but
And so
Yeah.
would you say it's important for all men to kind of know about that too?
yes, absolutely.
Do you feel that they do? I feel like women are a little more in tune with the Kegel thing. than-
I think women talk about it a little bit more than men.
Yes,
do.
yes.
Sure.
What about for people who do lift heavy things or work out with weights, or they are stressing their core a lot? Is this a concern for kind of how to, again, do we go back to the breathing? Is that...
We go back to the breathing and really being aware of our pelvic floor and using that as kind of a counter to that downward pressure.
Okay.
So, sure.
In the end, just to summarize, and because urinary incontinence seems to be the kind of the trigger for people to seek help, I think they get to a point where they just kind of want to know what's going on. There's a lot of hope, right? I mean, there's a lot of things we can do to improve our quality of life. You think people are getting that message? I mean, we're helping right now, but in general, are we more open to it?
That's my sense as I see people coming into my office. It seems like we're talking a little bit more about it. I encourage all my patients to go talk to your girlfriends and your mothers and your daughters and spread the word that there, is something we can do.
All right. Don't take the escalator.
That's
Take
right.
the elevator. Claudette Cole, thank you so much for being
you
with
for-
us today on Greater Living, talking about all kinds of pelvic floor issues. And I know it was of great interest to a lot of people watching us live. Thank you so much if you were participating and sending in questions. And thanks to our audience who also had questions. And
Thank you for having me.
yeah, great. Do we get to toast like John does too? I will just take a sip.
Here's to your floor.